for a case control?
Let's have a quick look here.
Okay.
I'm not sure that I necessarily agree that they don't think you should do a cohort study. Where do they say that?
It's, I think, in the study design section. Okay.
Excuse me.
So he said something about he never learned anything about my study design, or
No, sorry. That's just a misunderstanding. So no, this makes perfect sense what you're talking about. What you're talking about here is doing a study at baseline of peripheral blood cells in these patients, and then doing high frequency versus low frequency, and that is your exposure, and then your outcome
is going to be whether the patients will achieve a complete response or not to the therapy.
No, I think this is really nice. I don't think you have anything to be concerned about here.
Okay, so my second question is regarding the feasibility and the cost of a study. If I want to switch to the case control design, I think I will be faced with a problem because I don't have a frozen samples, or I haven't collected like the samples before the outcome has occurred.
No, you're absolutely correct. There's no reason. The only issue is, do you have any idea what proportion of patients would have the
yes. Like I tried, like I did my best to get numbers, okay? So I choose like in patients who are responsive to the therapy. Usually the failure or the progressive disease is achieved in 20%, happens in 20%. And patients who develop resistance to the disease usually achieve something about 55%. Okay, so those are the numbers I have and I will be working on.
Yes, but the question is, what proportion of patients are going to have increased frequency of CD28 negative T helper cells?
Okay, I don't have numbers about that, but it's quite common, like to in myeloma patients or cancer patients overall, but I can look up the numbers. How will I use those numbers when I get them?
Well, so this is really important because you're saying here in your sample size calculation that you're going to have 92 patients in each group. The problem with this is that if that assumes that the proportion of patients who are CD28 negative is going to be 50%. So you might have to adjust this depending on what you think that the actual proportion of patients who are CD28 negative is. You know what I'm saying?
I'm not sure because when I calculate the sample size, I use the outcome, right? The proportions of the outcome, not the exposure.
Yes. Let me see.
As regards the numbers on the proposal, I have updated those numbers. So, but in terms of outcome.
Yes, but that would be if you were looking at a randomized controlled trial and you were trying to figure out how many patients you need to include. And so this is different because you're going to have unbalanced groups.
Okay.
So it would need to be done slightly differently, or at least to think about it slightly differently. I don't think there's anything particularly wrong with what you've said here. But it's just, if you were going to be completely accurate about it, you'd have to think about if there was a big difference in the number of patients between the two groups, that would affect the number of patients you would need in your study.
Oh, okay, so I thought about like to enroll patients. That's why I think I mentioned something about consecutive enrollment. I thought like if I need, let's say, 50 patients in every group, so I will just pick 50 with CD28 negative that is high and 50 that is CD28 negative is low. Would that be correct?
Well, so it really depends, though. It depends on. So that's different now. That's not cohort. That's now you're talking about case control.
Oh,
And
because
because you're not just collecting everybody, and you're probably better off just collecting everybody
no,
in this
I mean like
study.
I'm selecting based on the exposure, not the outcome, like not cases control. I'm just
Yes, but it's still the same. It's the same thing
uh-huh.
because it's not a case control study. So you don't need to do a case control study. A cohort study is perfectly fine.
All right.
And in fact, it's probably more appropriate here because it's going to be more undifferentiated. It's going to give you a better answer, particularly
Awesome.
if you don't know for certain what proportion of patients at baseline are going to be negative or positive or high or low or whatever it is.
Okay.
So I think the way that you've designed this is perfectly fine. I wouldn't worry about it. You don't need to change it to case control. What the reviewer was saying is that you hadn't mentioned previously that you were going to do it like that. And sometimes it's useful earlier on, like in the specific aims page, to mention that you're doing a cohort study or of an observational perspective observational study,
All
because
right.
um, because it's just a bit unwieldy if you get to the research plan before you know what kind of a study the person's actually doing. But that's
Okay.
more of a style issue than anything else. So it's not a major issue. It's not a
Oh,
major problem.
all right. So
You
when
know,
I get the numbers for the prevalence of the CD28 negative and positive and overall population, what should be my next step?
um, all right, give me 1 second here.
Okay.
I just think the way you've done the sample size calculation is kind of like doing one for a
Exactly.
randomized controlled trial because it's
Exactly.
assuming,
That's the only one I know. Yes.
but you'll have to do one for an observational study instead. There are lots of different ways you can do this, and there are different ways you can find how to do it online.
All right.
If you do like a sample size calculation for perspective for observational study,
Right.
you should be able to find something.
Okay.
It's only because it doesn't the way it's put at the moment. It's pretty obvious that that's not the way it's going to really look in the end because you're not going to have equal number of patients in each group.
All right. Okay.
What you're trying to figure out with the sample size calculation here is assuming the difference that you're looking at in the two groups. What are the number of patients you're going to need to recruit to make sure that you have adequate numbers of both type? You know what I mean? So like
Uh,
it's not so much you need 70 patients in each group, it's that if only 20% of the patients have this, in order to show a difference in the two groups, you're going to need X number of patients overall to be able to guarantee that you include enough patients that have high
oh,
and have low.
okay. So it depends on the number of people with or without exposure,
That's
right? And
exactly right.
cohort. All right.
Yes.
Thank you. Thank you a lot. Okay.
But your proposal looks nice. You know, it's a nice idea. It's a very clean study to do,
All right.
and it makes sense. It's minor issues,
All right. That was very helpful. Thank you. Thanks a lot.
not at all. All right. For the sample size calculation, where do I write in the proposal? So you should write it after the statistic, or in or after the statistical analysis section. So it should really be around the same place as the statistical analysis section. And here's somebody asking me, do I have to calculate sample size for my researchers with time limits? So can I ask, what do you mean by that? You can unmute if you wish. Should I correct draft comments only for the final capstone? Well, so you should, for the final capstone, you should correct whatever you, if you feel happy with it after you've corrected the draft comments alone, then that's fine. But you may want to make other changes too, but that's really up to yourself. You don't have to do anything specifically. But Rabab Mohammed, you had a comment here. Do I have to calculate a sample size for my researchers with time limits? I'm really interested to know what you mean by that. Because it's a very good question, an important question. Gee, I don't see a person on any. Oh, there. Sorry, there. If it's for 1 year. So, I'm still not entirely sure what you mean, but what I really want to get across to you is why we do a sample size calculation. You're doing a sample size calculation not just as an exercise that is a requirement by the reviewers. It's not about that. You do a sample size calculation because you want to make sure that you're going to be able to answer the question that you're asking. So if you want to take the previous example we were just talking about. So what this was a study looking at the prevalence of a particular blood cell type in patients with myeloma and whether or not it was associated with long-term outcomes. And the thought was that if this was absent or low, then your outcome would be worse than in patients where it wasn't. And the sample size calculation that was done looked a little bit like a randomized controlled trial. And it said that you would need 70 patients in each group to show a 20% difference. And I really liked the fact that that May had done the work to kind of say what she thought the difference was going to be between the two groups and what would be a significant difference. And I thought about that. And the reality is this research hasn't been done before. And so you kind of have to make it up to some extent. You've got to try and figure out what makes sense to you because you don't know the real answer to that question ever. Because if you did know the answer to the question of what the effect was really going to be, then you wouldn't need to do the study. So there's always going to be some assumptions. Now, the problem is that if you use the power calculation as it is in that proposal in your final research study, then you would only recruit 140 patients. Now, what would happen if the prevalence of the actual low cell type was only 10% in one group and 90%, was 10% overall? That would mean that in your 140 patients, you would have 14 who had the low cell type, and you would have 126 who didn't. And that may not be enough to give you the answer that you need. And so it's really important to know what the prevalence is overall, or at least have an idea of what the prevalence is overall, so you can accurately calculate your sample size. And the idea behind doing this is that you're able to confidently state, if you have adequate power, that you will be able to answer the question that you're asking. So the power calculation is a tool for yourself to be sure that you're going to be able to answer the question accurately. And so I'm just looking at your proposal here, Bobby. So you're talking about lab information system. Yeah, so Rabab, so this is a really important point. So you're asking whether or not you should do it for 1 year, and um, if you do it for 1 year, then you don't need to do a power calculation. But the problem with that statement is that in your own research proposal, you said you only need 200 patients in order to find the difference. And if you only have 200 patients to find the difference, then you might be able to collect that number of patients in the space of a few weeks. And rather than spending all the money to conduct a study over 1 year, you will have your answer after a few weeks. And so the study will cost a lot less. So this is the point. This is exactly the point, that if you just set it as a predetermined time, you don't know how many patients you're going to collect in that amount of time. And so it's really important to be able to know that you need to do it for 1 year. You might not need to do it for 1 year. And certainly any reviewer who was reviewing this and wanted to try and give you some money to do this study would insist on knowing what the likelihood is that you'll be able to do the study over the amount of time that you've put forward for it. And so I think a power calculation is always useful, always useful. Somebody asked a question, do we have to write ethical considerations in the capstone specifically if the study design is an RCT? It's important to have at least a sentence on ethics to make sure that you are, it's more important in a full proposal where you would be very specific about this. But but maybe one line is enough for the purposes of this. Rayham Emad, I think this is a direct message, so Haley, you may not have seen this. Can you send me Rayham, REHAMEMAD, that box, please? All right, so let's see. Sorry, I'm just looking through, Saf, I'm looking through your proposal here. All right, so you said, it says, you said to me that calculation of deaths among doctors is very hard, but need to be many evidence around 1 to 2 doctors die every month. And I calculate a sample size of 124 events out of 2,300. It's true with a hazard ratio of 1.7. So 1 to 2 doctors per month. But you're only looking at healthcare facilities in Alexandria. Do you have 2,300 doctors in healthcare in all of Egypt. Okay, because in the proposal I thought it said just so 1 to 2 every month over 5 years. I mean, it's possible, but then, yeah. So I would just put that into the proposal. I would say what the evidence is that there are 1 to 2 doctors dying every month. I think that's really important because that's the big question when you're talking about an 18 to 49 age group. The fact that is there really that many people dying? But if you're going to be doing a population type study, you're going to have a lot more than 2,300 people, I would imagine, in the study overall. You'd probably have that many doctors, but you would need to have probably a larger number of non-doctors in order to kind of get enough events. But I think that's fine. It's just a question of saying in the proposal itself what the evidence is for this proposition that many people are dying. I would argue as well that there's going to be a problem, which is that the reality is that medical professionals are relatively better paid, better educated, potentially from higher socioeconomic classes than the general population. And so that can skew your results because you would imagine that the mortality rate amongst physicians in general or professionals would be much lower than it would be in the general population, where people might be more subject to poverty, to poor nutrition, poor healthcare. And so this is a really important point where are you going to, it's non-healthcare professions, but what does that mean? So it's non-healthcare professionals from various occupational fields within all government health sectors in Alexandria. All right, no, you've thought about that. That's good. You've thought about that. I see that now. I mean, it's interesting. I think it's worth seeing.
Doctor.
Yes.
In Egypt, many physicians and nurses die every month. This is a phenomena, like a phenomena in the last 2 years. So I think to compare physician and doctor against other healthcare professionals who are not in direct contact with the patient, because doctor and nurses in Egypt face a lot of challenges.
You know, and I think you actually thought this through pretty well. You know, it's not an easy study to do, but I think it's doable the way that you've constructed it. So I don't have a problem. I think that's fine. I was kind of asking myself all these questions as I went along, and every time I asked myself a question, I was looking at your proposal and you'd already answered it. I think the most important one is the fact that your control group is other professionals working in the healthcare system who don't have direct contact with patients, because
yes,
because you absolutely have to have similar groups, similar socioeconomic groups. So I think that's good.
Okay, thank you, doctor.
No problem. Let's see here. Okay, Rayham. Rayham, where you're having trouble calculating your sample size calculation is because you haven't clearly defined your outcome, and that really is the major issue. Your specific aim is understand the benefit of probiotics in preventing respiratory tract infections in young children. And what you're going to do is you're going to take individuals who have recurrent attacks of bronchitis and then randomly divide individuals into active intervention and control group. The active are the people who take the lactobacillus. So there are a few different ways that you could design this. You could do it as a study to see the number of fever cough events over a year in each group to show that there's going to be less in one group than another. In that case, it would be a very simple 2x2 table to say that there would be X percentage or X number in one group and Y number in the other group. And you could do your power calculation based on this, calculating the difference between two groups, so the numbers in one group versus the numbers in the other group. The other way of doing it would be to do time to an infection. So in that case, instead, you would do it as a kind of a time to event study, where you would have your outcome is the next event of an infection. So the individuals all start taking their medications at one time, and then you will see when they would have another event. That's a slightly different way of doing it, but it's also pretty simple power calculation to do once you know what your outcome is. But the key here is you have not clearly defined your outcome. Your outcome is understand the benefit of probiotics in preventing respiratory tract infections in children. What do you mean by that? Do you mean preventing the next episode of a respiratory tract infection in children who already have one? Do you mean reducing the frequency? Do you mean reducing the number over a particular year? Do you mean getting it down beneath a certain level? So you have to be specific. And when you make a decision about what your outcome is actually going to be, then you will be able to do your power calculation because you actually have a specific outcome that you can base it on. So for example, if you decide to say that in one group, well, so your outcome is not to reduce the frequency and severity of RTI, because that's two different things. That's two different outcomes. Reducing the frequency of respiratory tract infections means over a 1 year period, you're going to have less infections. Reducing the severity could be measured in a number of different ways, but that's not one outcome. That's two different outcomes, if you see what I mean. Because you can't test those together in one test. If I was to do a calculation to look at the reduction frequency, I would say in one group there are 10 infections in a year, in the other group there are 6 infections in a year. That's a clear reduction in frequency, and that's what we're looking for, and I'm going to power my study for that difference. But that's not severity, and you can't do your calculation for severity based on that statement. So severity is different. It's how long the infection lasts, if the patient was admitted to hospital, or whatever it may be. But that is not a single outcome. It's two different outcomes. And because it's two different outcomes, it's impossible to do a power calculation on it. Remember that you should be able to convert your outcome into numerics, into numbers. So for frequency, how many infections over a year, or time to next infection. For severity, how many admissions to hospital, the length of time people were sick. Honestly, that's probably too difficult. You're probably much better off looking at frequency in this kind of a population, particularly because most of them will probably be at home. But it's not as simple as saying the outcome is to reduce frequency and severity. That is your research question, is does it reduce frequency and severity of RTIs? And that's a perfectly good research question, but it's not a hypothesis. Your hypothesis has to be stated as, my hypothesis is that treating children with recurrent respiratory tract infections with lactobacillus and bifidobacterium will reduce the frequency of infections from X to Y. Then you can do your power calculation. Or it's going to increase the time to the next infection from 2 months to 6 months. Again, that is a very clear outcome that can be measured directly. But you do not have a measurable outcome in your proposal as it stands right now. So I'm not saying that you have to focus on reducing the frequency of respiratory tract infections. What I'm saying is you have to make a decision about what you think is the most important. So I know nothing about this. I know nothing about respiratory tract infections in children, except that my children keep on getting sick at home. That's all I know about it. But, you know, so it's really you as the researcher are the person who needs to kind of make a decision about what you think is important to you. So do you think it's more important for them to have a greater time to their next infection, or to have more or less infections over the next year? And so this is a perfectly good study, and this is exactly what we're looking for, but it's being held back by the lack of a clear outcome. I think you know what I'm saying. All right, let's see. I gotta go back up again. It's a very important question. To calculate sample size, I need to know the proportion or percent of the outcome, but actually I don't know that in my population of interest. Can I use general studies done with 2 treatments that I'm comparing? Yes, you can. You can do anything you want with this, really, once it makes sense to you. So remember, this is a tool you are using. So, you know, to go back to the example that I use all the time, let's say interstitial nephritis and using steroids for interstitial nephritis. So I might have some studies showing that 20% of patients with acute kidney injury end up on dialysis, but I don't have any good studies on whether or not patients with interstitial nephritis end up on dialysis at that rate. And so I kind of have to make a decision at that point. I have to decide, am I going to use that number that is being shown in other types of renal failure and base my power calculation on that? Or is there a particular reason why I might think that the rates are higher or lower in patients with interstitial nephritis? And so what I would have to do then is use my knowledge of the literature, my knowledge of patients with this disease, and my kind of almost like my common sense to come up with a number that makes sense. And then think about what the outcome should be in the group of interest, in the intervention group, and whether that would be lower. And so a lot of this is an art rather than a science to some extent, because you're trying to answer a question in the power calculation that you don't know the answer to. It's a really important point. Your power calculation, the idea is that you're trying to figure out how many patients you will need to include in your study in order to answer the question as you stated it. So what I mean by that is, I want to know if I think that 20% is roughly what the rate of AKI requiring dialysis would be in my group. And I think that it would be a really important, clinically important outcome if we could get that rate down to 10%. So what I'm going to do is I'm going to do a power calculation to calculate how many patients would I need to answer the question, does this reduce incidence from 20 to 10%? And if it does, then I have my answer. So it's a tool you're using to help yourself. That's the whole point. People don't think about it like that, unfortunately, but it really is. It's all about trying to make sure that at the end of the study, that you will be confident that you have answered the question as best you can. Oh, that's interesting. In a study comparison of 2 drugs in the treatment of a disease, better to state an hypothesis that we want to prove the superiority of one drug over the other, or say it's non-inferior. It depends. It's easier to do a superiority study. The sample size calculation is easier for a superiority study, but it really depends on the drugs themselves and the reasons why you're doing the study. So for example, you know, most of the time we're doing superiority studies because we want to prove that your new treatment is better. But there are times when we just want to prove it's just the same or just as good. An example of this would be if you had an oral drug, and the previous drug was given intravenously. And obviously, it's much cheaper and more efficient to give drugs orally. And so you might be perfectly happy with a result where you get an equivalent result as the previous drug by giving it orally. And you don't necessarily need to prove that it's superior. But in a non-inferiority study, you really need to be able to justify why you're doing the study. If you're going to test a drug or a treatment that you think is going to be just as good as one that's already being used, then you need to be able to say why you want to do this study. Is it because maybe the one that's being used currently has a lot of side effects? In which case that would make sense. But that's really the only question. It's not that one is better, it's that it really depends on the context. Do I have to do a registry for any kind of study, only RCT or clinical trial? Yeah, pretty much all clinical trials these days need to be registered with clinicaltrials.gov. And most journals will not publish papers of clinical trials that have not been registered with the registries, because the sense is that it's subject to being changed and it may not be ethical. So yes, in general, that's the way it has to be these days. Can I do a study and its sample size differs from a previous pilot study, being less based on calculation with guidance of how to get difference in that pilot study? So I think what you're trying to say there is that your sample size will be different because you're going to be able to show that your study would be different as well in some respects. And again, I think that's fine. You know, the worst thing that can happen to you in a clinical trial is if you were to spend time, money, and effort doing a study, and at the end, you get a positive result, but a p-value that is non-significant because you didn't include enough patients. And that's what your sample size calculation is going to do. It's going to make sure that something like that doesn't happen. Like if you only include 20 patients in your study, but you have an effect size of, a hazard ratio of 2 for the outcome, but your p-value, because you don't have enough patients, is 0.04, 0.06, 0.07, then you're going to be very, very disappointed in yourself, because if you'd only included another 5 patients, you probably would have had a positive result. So the power calculation is about helping you. It's about making sure that your study has the result you want to have and that you can trust the results of the study. So that if it's negative, you're going to know that it was not negative because you didn't include enough patients. And if it's positive, you're going to know that you didn't include too many patients and cost too much money by doing too many patients and having too many patients in your study. So that's what it's designed for. It's in order to help you to find out how many patients you will need to include in your study in order to get the answer you're looking for. Time for a throat lozenge, I think. This is our last office hour together. I hope that this has been a fruitful experience for you all, and that you feel like you've learned something. We see the progress every time with people's proposals and how they grow as they learn and understand more and more about how this is done. If there are specific issues with reviewers that you might have, I'd like to hear about them. I know that there were people who messaged me last month and I missed some emails, and I apologize for that. That was I was on service all month and unfortunately didn't catch up until this week. I tried to respond to everyone. I think I've basically caught up at this point. But if I haven't, please let me know. You're welcome to email me directly. I also think there is a problem, which is that for some reason, when I get the notifications through Canvas, they're not coming through always. So here is my email address. So you can email me directly if you need to. But this has been a pleasure as always. It's always fun learning what people are interested in and how different people's interests are to what I'm interested in. You know, I work primarily as an ICU nephrologist. And so what I see is a very different group of patients to somebody who might be working a community setting in Egypt. And seeing as there's no questions, is anyone planning on heading down to the Valley of the Kings for the eclipse in 2027? Or have you heard about that yet? It's going to be extraordinary. Apparently the Luxor is going to be in the path of totality for 6 whole minutes, which really is extraordinary. I went to see the eclipse in northern New England last week, and it was the most amazing experience of my life. And I can imagine that standing in that incredibly historic place and watching the sun go dim over you would be a life-changing experience. I'm very jealous of you that you're living so close to it. Apparently there's some tour groups trying to go from the US and they've already sold out 3 years in advance. For questions, we might leave you go a couple of minutes early today. And appreciate all your questions as always. I think best of luck with your final drafts.
Thank you, Dr. McMahon, for today's session. As a reminder, this recording is going to be available to you on Canvas. So if you want to go back and review any of the things we talked about today, that will be available to you. Of course, you're welcome to contact Dr. McMahon directly for any questions. But if you have any issues with Turnitin or Canvas, please feel free to email us at ecsrt@hms.harvard.edu, and we'd be happy to help with any technical issues. Thank you all, and we look forward to receiving your